I'm Dr. Jackie Harris, and I am a neurologist and neurodevelopmental specialist at Kennedy Krieger and Johns Hopkins. And I work completely in genetics and specifically in epigenetics. And so I really only see patients with syndromes like Wiedemann-Steiner, these epigenetic syndromes. And I sort of specialize in their neurologic care and developmental and behavioral issues, and see lots and lots of kids with Wiedemann-Steiner. And so I'm here today to talk to you a little bit about what we've learned about neurology and cognition and behaviors in Wiedemann-Steiner, and a little bit about what we still need to learn and what we hope to learn more about.
Michael's up there.
Some research. Yeah, so that's about it, and I will start. Libby, would you allow me to share my screen?
And Dr. Harris, I can tell you that we are just thrilled to have you, because especially with COVID times, we all have become more and more familiar with our children's behavior.
Absolutely, I am sure.
Let me. Okay. Let me know if that allows
that
you.
worked.
Okay. Have everybody turn off their videos except for Dr. Harris at this point, and then we'll get her presentation started.
All right, everybody can see that okay? Great. So for this talk, we're gonna just provide a really quick intro to neurodevelopmental disabilities in general. Then we're gonna talk about the specific ones that we see in Wiedemann-Steiner, going into the specific behavioral concerns in Wiedemann-Steiner, and then talk about potential clinical, behavioral, and educational strategies for right now. And then we're gonna close the talk with a very brief discussion about research. So neurodevelopmental disabilities include things like intellectual disability, ADHD, autism spectrum disorder, specific learning disabilities, cerebral palsy, language disorder, anxiety, epilepsy, and many more. And as you can see, these are descriptions of certain cognitive or behavioral profiles in a child, and don't necessarily tell us anything about the underlying reason. And so because of that, overlap and multiple disabilities are the rule, not the exception, right? So if just because your child may be diagnosed with intellectual disability, it's actually more likely, not less likely, that they may also have anxiety or ADHD or cerebral palsy or one of the other classifications of neurodevelopmental disabilities. And what we know is that certain patterns of cognitive strengths and weaknesses have been associated with specific genetic syndromes. So certain genetic syndromes may or may not have intellectual disability as a part of them. They may have language disability or visuospatial problems. They may have behavioral features like ADHD, anxiety, autistic features. They may or may not have seizures as a part of it. And so the more that a certain syndrome is studied or known about, the more we can kind of craft this specific phenotype, and that really helps us to guide families in knowing what to expect for their child and how best to address the problems when they arise. And so does Wiedemann-Steiner syndrome have a particular neurologic, cognitive, or behavioral profile? Well, the answer to that is we think so. However, true detailed characterization of neurocognitive and neurobehavioral phenotype of people with Wiedemann-Steiner syndrome is limited to non-existent. So there are many studies about Wiedemann-Steiner that are published, but very, very few that focus on the neurodevelopmental features. And the only one that really focuses on that specifically had a little tiny sample size of just 6 patients. So, so not a lot is really published. What we do know from what is published that most people with Wiedemann-Steiner have fall in the mild range of intellectual disability, although there are certainly children who fall within the average range, but with some challenges, and those who scatter all the way down to more severe or profound intellectual disability. We know that there's significant anxiety and significant executive functioning issues, which we're going to talk about more throughout this talk. There's often social cognitive issues, sometimes accompanied by autistic features. And we know that these behavioral issues in Wiedemann-Steiner can become pretty severe, especially as the kids get older, and they often lead to adaptive functioning that is lower than cognition. So, you know, these kids can be pretty smart and have a lot of skills, but a lot of times their behaviors make them more impaired than they otherwise would be. A lot of people with Wiedemann-Steiner seem to have poor sleep even after their obstructive sleep apnea is corrected. We're going to talk a little bit about that. There's often hypotonia or low muscle tone that is pretty evident early in life, but improves with age. Seizures are more common than in the general population, but they're still they still are only in the minority of patients with Wiedemann-Steiner. About half of patients have a finding on brain MRI, but that finding on brain MRI usually is not significant. And there's an increased risk of lumbosacral spine abnormalities, including spina bifida occulta and tethered cords. So that's what we know so far. But again, we really need to know a lot more details. So going through these features, hypotonia seems to be present in the majority of people with Wiedemann-Steiner, about 73% in the latest case series that we published. This seemed to be more than was published in previous studies, but it was likely just not something that was reported, especially when older kids are described. They may still have the hypotonia, but it may not be a predominant feature, and so often it doesn't get reported. So hypotonia just means low muscle tone, and it can result in delayed acquisition of motor milestones and balance and coordination issues. More than half of patients with Wiedemann-Steiner have a delay in walking in what's reported in the literature, but even after that walking threshold is crossed, other issues like poor balance and coordination persist. The treatment for hypotonia is physical and occupational therapy where it is needed. The hypotonia is the worst in the infant and toddler years, but and gets better with age, but the issues still persist, especially these balance and coordination issues. And that recent case series shows a slight trend that loss of function variants, so specific genetic mutation that caused the whole protein to not be made at all, that they seem to have a little bit more hypotonia reported than those with other types of variants. So brain MRI findings. So some sort of brain MRI finding that's read out on a report are present in about half or maybe a little less of people with Wiedemann-Steiner syndrome. And these are almost all mild findings with really no clinical significance. Some of the more common findings are absence or underdevelopment of the corpus callosum and abnormal or delayed myelination. And, you know, we find these things and we say, okay, this kid has something going on with their brain. They're not specific. They don't tell us anything specific. And usually the reason we say they're not significant is that usually by the time your child with Wiedemann-Steiner has had a brain MRI, it's because we were looking for a cause or a reason for the problems they were having. So basically, you know, you got a brain MRI that says that the child may have some neurodevelopmental issues. Well, you already knew that, right? That's why the child's being worked up and evaluated and got the brain MRI in the first place. Very rarely are there findings associated with seizures like dysplasias. That's really not common. So then the next neurologic feature is the lumbosacral spine abnormalities. So this basically means that in Wiedemann-Steiner, there's frequently abnormal development of the lowest portion of the vertebral column and spinal cord. So in the most severe cases, which is very rare in this syndrome, the spinal column can be incompletely closed and damage can occur to the cord. Slightly more frequent than that in Wiedemann-Steiner is a tethered cord. And this is where the cord is inappropriately stuck to tissue and cannot move freely. And so when that sticking occurs and the child grows and the sticking persists, then that could potentially cause stretching and damage to the spinal nerves. This can look like problems with movement or sensation in the legs, bowel or bladder problems. Again, this is much more frequent in Wiedemann-Steiner than it is in the general population, but it is still the minority of patients with Wiedemann-Steiner. So most kids with Wiedemann-Steiner do not have a tethered cord. The other thing I want to mention is you heard me say a symptom is bowel or bladder problems, and that is true. However, potty training problems in Wiedemann-Steiner are super, super common, right? A lot of you know that even when your child cognitively has the ability to know how to use the potty, sometimes that's a struggle that persists longer than you expect it to. And so potty training problems are generally not a tethered cord. But again, if there are other issues or, you know, it's really seems to be above and beyond the normal potty training problems that are seen in Wiedemann-Steiner, then it may be worth checking. Seizures. Seizures, from what's reported, they occur in about 20% of people with Wiedemann-Steiner. This seems to be maybe the reverse of the hypotonia in that the seizures seem to be maybe more common in those with a missense variant. So a variant that doesn't necessarily make the whole protein not made, but just causes a spelling change there. And so it is, again, we need more data to say this for sure, but it seems like there may be a slight trend that people with a missense variant have more seizures than others. We really, at this point, do not know any more specifics about types of seizures, types of EEG patterns, or if there are any treatments that are more or less effective for seizures than in Wiedemann-Steiner than in other kids with seizures. We just don't know enough. There aren't enough kids. There aren't enough case reports. So we need to understand more about this. So now cognitive issues. So in earlier studies, this was quoted that about 30 to 60% of patients with Wiedemann-Steiner had some sort of cognitive disability. However, this is likely due to underreporting of these issues in the published cases. So when you write a genetic case report, it's often a geneticist or another clinician, or it's a compilation of multiple different clinicians kind of describing the syndrome. And frequently the child's neurodevelopmental profile is really not well reported in those syndromes. There may be a lot about growth or facial features or organ system anomalies, but not necessarily a detailed description of the neurodevelopmental issues, especially if the child is less profoundly impaired. So, you know, if a child is walking and talking and things like that, a clinician who isn't specifically looking for that for this publication may not, you know, kind of know to publish that as part. So I do not think that that's 30 to 60% in any way is accurate. In the more recent study that I was a part of, that came out this year, 97% of the 104 patients discussed had either intellectual disability or global developmental delay if they were maybe too young to be called intellectual disability at that point. So that seems much more consistent with my clinical experience, which is a lot of times the cognitive issues in Wiedemann-Steiner are more mild, but they don't have to be, number one. And number two, as I'm sure most of you know, almost all of them have it, right? So almost all of your kids struggle with some aspect of thinking, learning, memory, and those kind of things like that. So we do think most are in the mild intellectual disability range, although there are several patients who are much more profoundly affected than that. And we really know nothing else about specific strengths or weaknesses within that profile because it just hasn't been published on yet. That very small study that I talked about earlier with 6 patients from 2019 suggested that patients with Wiedemann-Steiner have a high prevalence of autistic features, including social communication issues, which are there despite the kid's desire for socialization. They have issues actually carrying it out, and rigidity and emotional dysregulation. So from that very small study, those seem to be some consistent patterns that they came up with. And so what does it mean if I say mild intellectual disability or severe intellectual disability? Well, this is kind of an idea of what we think about as clinicians when we're talking about intellectual disability. So often we correlate it with a number or a full scale IQ range. And, while that's fine, what's really important is kind of how do we expect functioning in the world when we're talking about these different levels of intellectual disability. And so if you have what we call borderline cognitive impairment, which means your IQ is in the 70 to 80 range, so it's more than one standard deviation below the mean, but it is not quite in the intellectual disability range yet. And we expect that these kids, reach a potential of 6th grade academic level, and they are fully independent and employable, but they still probably require some supports in the community to receive their maximum potential. And there are certainly kids with Wiedemann-Steiner who fall into this range. Very commonly, kids with Wiedemann-Steiner fall into this mild intellectual disability range, which is often associated with an IQ of about 50 to 70. Usually these kids function reading and writing more like a 4th grader. They could be relatively independent, but definitely need some training. These kids function more like a 10-year-old as an adult. And so 10-year-olds can do lots and lots of things, but definitely need supports to be able to maximally function in the community. And again, as you get into more severe levels of intellectual disability, moderate, severe, and profound, the need for supports increases. So behavioral issues. So studies would suggest, previous studies would suggest that behavioral issues are present in 40 to 70% of kids with Wiedemann-Steiner, which is kind of a wide range and seems a little bit low. We think from what we've seen in our pretty large pool of kids with Wiedemann-Steiner that some sort of behavioral issues are nearly universal. And frequently, the families, especially the families of kids who are a little bit older, not the infants necessarily, but kids a little older than that, more like school age, frequently the behaviors, if the families could identify one thing to fix, that's what they say they would fix. Generally, we see anxiety and ADHD together with the cognitive issues, and that's the rule, not the exception in Wiedemann-Steiner. And in our experience, patients with Wiedemann-Steiner perform worse at school and have lower adaptive functioning than their cognitive levels would suggest due to their behavioral problems. And so a lot of times we see a kid with Wiedemann-Steiner and you get them, kind of to do one-on-one testing, and they really do pretty well. They have lots of skills. They have lots of problem-solving abilities, but when you put them into a real-world situation, their behaviors, their anxiety, their disorganization and impulsivity from their executive functioning really hold them back from being able to actually perform the way that their cognitive level would suggest they can. And so that, tells me that behavioral issues are a major thing to tackle in this syndrome. So one thing we see is behavioral sleep issues. So we already know that more than 75% or more than 3/4 of those with Wiedemann-Steiner have obstructive sleep apnea at some point in their life, and frequently that requires their tonsils and adenoids out. However, there is more to sleep than just sleep breathing problems. And so that study from this year suggests that about half of kids still have sleep issues, even after the sleep apnea is resolved. So there are behavioral sleep issues that are coming up. So not just the sleep disordered breathing. So, whether that is difficulty falling asleep, frequent nighttime wakings, tiredness during the day, inappropriate sleep patterns as far as when they want to sleep and when they want to be awake. All of these things are pretty frequent in about half of kids, at least, that's reported. And this may be underreported and maybe much more frequent than that, that we're seeing these issues. And that can be really disruptive to the kids' behaviors and really disruptive to families too. So anxiety. So if I were to say the maybe one biggest thing that I see in Wiedemann-Steiner, it may be anxiety. So in Wiedemann-Steiner, we see every type of anxiety, generalized anxiety, specific phobias, a number of things. And it's frequently can get very severe. It can manifest early on in its presentation more subtly, like with perseveration or adherence to routines, and later become more and more severe and apparent. Environmental issues can certainly worsen it. So, your kid may be doing fine, but they'd certainly have some features of anxiety, but then, they just are really in a classroom setting that's not good for them that year, and that could really set it off. Structure is obviously very helpful, and this should be treated in a multifaceted way. So with therapy, educational plans, and medication, and we're going to go into that a little bit more later. ADHD and executive function is the most common thing I see after anxiety. So, and it's often more apparent in the youngest kids before the anxiety really manifests itself as obviously. The anxiety and the ADHD play off each other and worsen each other. And the ADHD and executive dysfunction, ADHD is what everybody's familiar with. I really like the term executive function dysfunction better because I think it better describes what the syndrome looks like. So it's not just about hyperactivity or poor focus. So we're also talking about impulsivity, poor organizational skills, emotional lability, etc. So the whole spectrum of executive dysfunction. So what if we were to say, okay, we're ready to create a neurodevelopmental profile in Wiedemann-Steiner, what might it look like? Well, we need a lot more work to complete it, but we think it is intellectual disability. We don't know about language disability or visual spatial problems. Yes, anxiety. Yes, autism. Yes, autistic features sometimes. And sometimes seizures, although not super commonly, and hypotonia early on. So where can we go from here? Well, we could better understand the function of KMT2A, leads us to better understanding what is happening in the brain in Wiedemann-Steiner, and leads to the specific profile that we see. So what can I do now for my child's neurodevelopmental issues might be a question that a lot of you have. So first, from a neurologic and from a medical neurologic standpoint, you have a high suspicion for seizures and treat if present. That said, seizures, again, are present in the minority of kids with Wiedemann-Steiner. And so given that that is the case, I do not think that you need to put a monitor on your child at all times or sleep with them or anything. It's more like a, if you see something, say something kind of vision where, it's more common than in other kids, but it's not something you have to worry about every day if you're not seeing anything. And seizures will declare themselves if they come. They don't hide from you. We're not currently aware that one seizure medicine is better than another for Wiedemann-Steiner. When should you or your provider consider an MRI of the brain? Well, if the kid has a new diagnosis of seizures, after a significant cardiac event or surgery, if your child might have a congenital heart issue, and if development is regressing or not progressing at all. An MRI spine should be considered in the following situations: a sacral dimple that is not able to be adequately evaluated with an ultrasound, or a sacral hair tuft, should always have one. A new loss of continence. So again, I don't want every potty trained Wiedemann-Steiner, every not potty trained Wiedemann-Steiner kid to feel like they have to rush out and get an MRI of the spine. It's more so, I'd be really concerned if a child was previously continent and then suddenly lost it. With leg spasticity, leg weakness, or leg sensory issues that's more than arms or other parts of the body. Educational. So kids with Wiedemann-Steiner need to have a good IEP targeting their areas of weakness. So for most kids with Wiedemann-Steiner, intellectual disability or autism spectrum disorder will probably be the appropriate IEP diagnosis. Obtaining good neuropsych testing specific to your child to tailor an education program. So, and this neuropsych assessment should be done by someone used to testing children with significant disabilities. And I starred this one because we're going to talk about this a little bit later in the research portion. 504 type accommodation should be a part of the IEP for the executive dysfunction. Fine motor disabilities are really common in Wiedemann-Steiner. I'm sure a lot of you know that much better than I do. And so I am a big proponent of handwriting circumvention. I do not believe in, making another barrier to kids to frustrate them or make them not like school or make learning difficult for them. So, in 2021, there's just no reason that the kids have to write by hand. So I am all for handwriting circumvention early and often. And a behavior intervention plan is frequently necessary for many children with Wiedemann-Steiner, or possibly even specialized classrooms or services at school. Therapies, early involvement with infants and toddlers in the first 3 years of life. Physical therapy if necessary, particularly with the hypotonia. This is frequently something that little kids have a lot of physical therapy, and the frequency of it lessens as the kids get older, but often it's still useful for balance and coordination issues. OT tends to be something that's needed throughout life to help with activities of daily living and fine motor tasks. All that said, anyone who has seen me in clinic knows that I say you always have to have good balance, though. There are lots and lots of studies that say that therapy is good and helps. There are not so many studies that say that more therapy is better. And so I want your kids to have therapies, but I also want you all to maintain family sanity and allow children to be children and development to take its course, and families to be families. So I'm not a proponent of a kid who goes to an 8-hour school day and then 4 hours of therapy in the evening, and the parents are pulling their hair out because they don't have time to do anything else except run this kid to other therapies. The siblings are struggling because they're being left behind. That's not what I recommend. So balance is very important when choosing your therapies. Keep the things that seem to be continuing to help, and reduce or drop the things that are not. Sleep. The take home point here is there's more to sleep than breathing, right? So if a child is, just because a child's fixed the breathing problems doesn't mean that the sleep question should be totally dropped by providers. So sleep routine and sleep hygiene is very important. Lots of kids with Wiedemann-Steiner, if you have this available to you, can benefit from a sleep clinic that includes behavioral management as a part of it. Of course, make sure the sleep breathing problems are addressed. That is a medical issue that obviously needs to be taken care of and taken off the table first. Melatonin is very safe and can be very useful if there are problems with falling asleep, especially, and other meds when they are needed. Behavioral therapy. So this could be a really crucial piece for Wiedemann-Steiner families. ABA therapy is not only for autism. So even if your child with Wiedemann-Steiner does not have a diagnosis of autism, it doesn't mean that ABA therapies or ABA principles may not be useful to them to correct certain behaviors. So these are ideas that can be used with many developmental disabilities. Autism does not own that. When you are if you are able to get behavioral therapy services are one of the most few and far between and needed services. So I totally understand that many families in many regions just can't find a behavioral therapist that they're able to work with, and I get that. But when you can and you do have options, try to find a place that is accustomed to working with children with developmental disabilities, because obviously the behavioral therapy needs to be targeted towards that. Family buy-in to the behavioral therapy is super important because the implementation of strategies at home, as well as working with the school, is essential. And the best success to behavioral therapy is with a team approach. So therapist teaches family, therapist teaches school, school gives feedback to therapist, school gives feedback to family, family gives feedback, et cetera. And then plus medicine from your providers when it is appropriate. And that is kind of the best way to tackle this, is in this multi-faceted approach. So anxiety. So like I mentioned, anxiety is incredibly common in this syndrome. Significant anxiety can look like autism, but it is often treated differently. So if your child has Wiedemann-Steiner and someone is giving you an autism diagnosis, that is fine and it may be appropriate, but just make sure that anxiety has been considered. Significant behaviors can be common in some kids with Wiedemann-Steiner, and behavioral therapies can help these, but you just need to make sure that if the behaviors are possibly triggered by underlying anxiety, that is addressed, and that can be addressed medically, pharmacologically or therapeutically. Sensory processing issues are common in Wiedemann-Steiner, and sometimes those can stand alone, but those also could be a clue to some underlying anxiety. And in my experience, SSRI should be first-line pharmacologic therapy for treatment of anxiety in Wiedemann-Steiner. It doesn't mean that these always work for everyone. And it doesn't mean that kids with Wiedemann-Steiner don't sometimes have to go to second line, third line, et cetera, or layered therapies. But we think that it's possible that the mechanism of SSRIs may address some of the underlying neurologic mechanisms underlying the cognitive and behavioral function in these syndromes. In this syndrome. And so, I generally do recommend that if we're thinking about pharmacologically treating anxiety, that we think about starting with an SSRI. ADHD and executive dysfunction. So as far as we know right now, ADHD and executive dysfunction in Wiedemann-Steiner should be treated like ADHD and executive function in everybody else. So stimulants are first line. Alpha adrenergics may be used for little ones or in conjunction with stimulants or in a stimulant failure or in certain combinations where this may just be the most appropriate. Combinations of medication, behavioral therapy, and school modifications are the best treatments for executive dysfunction. Unfortunately, because it's hard, because we all have busy lives, but home modifications are also frequently necessary. Again, the ADHD and executive dysfunction, like I mentioned before, it doesn't have to look like hyperactivity. It can be manifested a lot as impulsivity and poor emotional regulation. And the combination of these things together, again, is the rule, not the exception. So with that, I'd like to tell you a little bit about ongoing research. So we really want to learn more about cognition and behavior in Wiedemann-Steiner at Kennedy Krieger and Johns Hopkins. So why do we want to learn more about this? Well, for several reasons. Number one, a study like this can help us to develop outcome measures for future clinical trials in Wiedemann-Steiner. So all of the kind of therapies or medications or things that I've talked about in the talk today are really just treating symptoms. We don't, as of right now, have a therapy to treat kind of the underlying molecular mechanisms of Wiedemann-Steiner syndrome. However, with current developments in research, I am not at all exaggerating when I say I think it is very, very close. So, potentially, 2 to 3, maybe 4 years away, or less, could we have actual pharmaceutical therapies that are targeted towards the underlying disorder in Wiedemann-Steiner. The problem is that if those were to come even right now today, we aren't ready for them. And the reason we aren't ready for them is because we don't know as much as we should about the cognition and behavior in Wiedemann-Steiner, so that if that's what the therapies are going to target, we need to understand those things so that we know, whether or not they work, so that we can test them in a clinical trial. In addition to that, if we understand better about what the cognition and behavioral profile looks like in Wiedemann-Steiner, then that can help us to best direct therapeutic, educational, and medicinal resources correctly in our kids with Wiedemann-Steiner to help them get the best outcomes right now, in school, at home, in their lives. And so I work with a neuropsychologist at Kennedy Krieger, who Dr. Rowena Ng, and she's conducting a study of questionnaires, looking at some of these questions, and then planning to follow up these questionnaires with more in-depth evaluation of patients with Wiedemann-Steiner. And Rowena, if you wouldn't mind turning on your video and saying hi really quickly.
Hi, everyone. Yeah, loved your talk, Dr. Harris. But yeah, I'm one of neuropsychologists working with Dr. Harris at Kennedy Krieger. So very excited to meet everyone. And hopefully, with joint efforts that we can kind of get to know a little bit more about Wiedemann-Steiner, and that we can provide better, more targeted treatments to help families. So.
Thank you so much, Dr. Ng. So that's what I have for you today. And I am super happy. And so is Dr. Ng, if you have questions for her, to take any questions.